what I thought I would do is talk about some ways that we've begun to understand migraine or migraine, depending on how you prefer it to be said, in the last 10 to 15 years. I'm going to get into the weeds in some of these things, and happy to take questions at the end about any one of the weeds that comes up. Migraine's not the only headache problem. Indeed, this list that I've got up is the International Classification of Headache Disorders, is the 3rd edition, the current edition. What headache people think of loosely, well, I was going to say as a Bible, but that's probably a bit pejorative. So I think of it as our guiding lights, you might say. Migraine is listed as number 1 for reasons I'll come back to. And the others are listed there. Some of them you'd be aware of. Most people, if I said tension type headache, would think they know what I was talking about, but I'm not sure I know. I've never met anyone who had a sentence, an evidence-based sentence to say on tension type headache, apart from not understanding it. Cluster headache is something I've been interested in for a long time. I discussed there are rarer forms of headache, and the classification committee, of which I'm a member, got a bit lazy, I think, after 3, and then stuck everything else in number 4. So there's a range of things that are well understood, not well understood in the sense of obvious, and not understood at all. New daily persistent headache would be a good example of that. Secondary headaches. The concept is that if you have an infection or someone hits you on the head, if something happens to you that causes pain, it's called a secondary headache, secondary to the meningitis, secondary to the trauma. The primary headache disorders, the concept is they're disorders of themselves. They don't require an external agent or agency to be able to activate them. We're a little bit between a rock. We're a little bit unsure, I think, about what to do with cranial neuropathies. Many of them are demonstrably secondary, and that's trigeminal neuralgia, for example, typically is regarded as conceptually as secondary. So I'm going to talk about migraine, but I don't mind talking about any sort of headache, really. This is something called the global burden of diseases, and this is the global burden of migraine. The World Health Organization keeps tabs on disorders and their impact on society globally, as you might expect. And this is a subgroup of work that's being done around headache, which just goes to show you what a broad problem that it is. You see Europe up there is a bit, you might say, a bit of a hotspot. Part of the variation here is to do with measurement, I think. There are some countries, you might notice North Korea, there's no measurements are being made because that's just not a thing. And there are 1 or 2 other places where no measurements are being made, but in the generality of things, we've got pretty reasonable, we've got some estimates, and some I think are better than others. Not everyone talks about their headache. I think if you looked at Africa from the middle down, it's hard to think that some of that is not due to reporting, lack of reporting, although some of it may well be biological. There's some reasons for thinking about that. So this is a very broad problem, which is why I'm interested in it, because if you tweak migraine, you tweak it in a lot of places. The best estimates we have put the migraine population in the world as about 1.1 billion people, more 1.2 billion. So serious numbers. And it's highly disabling. Numbers don't matter so much, but the colours and the order of things is important. So of neurologic diseases, stroke is considered the most burdensome. That won't surprise you because it's common and the consequences are quite devastating and quite often permanently devastating. Migraine is considered the number 2 in the burden stakes. Some of headache people wear this as a kind of badge of honour. I think of it as a badge of shame more than anything else. The reason it's so burdensome in disability terms is not because it shortens life, but because it very much constrains life on particular days. So whether you can't move around because you can't move, or you can't move around because it's intensely painful to do so, as long as you can't move around, you don't function in society. Broadly speaking, that's the way the World Health Organization thinks about this. This is not headache people saying this, is the World Health Organization. And you see Alzheimer's comes in number 3, meningitis number 4, an infective disorder. If you look at under 50s, migraines are the commonest cause of disability by the measures that are used in under 50s. It's a real problem in that way. Now, migraine has its favourites, so to speak, and it favours females over males. And I'm showing you there the distributions. And you see that migraine is the green, I suppose, khaki, and it's clearly a this picture tells you a couple of things. One of the things it tells you very clearly is that migraine is more common in males and females, something I'll return to, and it's a disabling problem that when you look at the distribution, for example, of stroke, which tends to be a problem of later ages, migraine is a problem of younger ages. Arguably, cynically, and to get the attention of government, it's fair to say that migraine is a disorder substantially of taxpayers. And so one could argue that it was useful to have taxpayers engaged in economic activity. Indeed, I think that's the current orthodoxy. It's an expensive disorder. This is some European data. Well, it was European when it was collected, but I guess it's European plus UK now. So these are a proportion of patients seen, getting on a preventive if they're seen by a general practitioner. In Spain, it included some neurologists. And so you look at the UK, episodic migraine means migraine that's occurring on 14 days or less per month, and chronic migraine means migraine that's occurring on 15 days or more per month. The line in the sand of 15 is nothing more than a line in the sand. It's the classification committee couldn't really agree on it. And so we ended up leaving it at half of 30, half the number of days in the month. So it's very artificial. I'm not going to try and defend it. It is what it is. It's used by regulators, so it's nice and people like that. You see that a good proportion of patients with chronic migraine, a fifth, are getting on a preventive. And that in the UK, 13% in France and 4% in Spain. But if I say that chronic migraine means you've got 15 days or more per month, it's hard to imagine why anyone with 15 days is not, or the large proportion are not on some form of preventive. So this reflects vast undertreatment. And then, of course, you look at the costs. The cost really revolves around episodic migraine, which is the largest part of the migraine problem. It's 90% or more of migraine. People who have less frequent migraine, there's more of them. And that's why they're expensive. These are euros in 2020 numbers. I don't know what's happening in Spain. They must be doing a lot of prescribing, is all I can think for that. This goes back to the prevalence data. I'm going to make a few points around this. Migraine certainly occurs in children, about 6% of children by the time they're about 8 or so. 6%, it's quite a lot. It takes off in favour of women with puberty, and the female dominance is retained for the entirety of the migraine spectrum. So you see there at the peak, it's about a third of adult females in the US. The UK European number is more or less the same, 10% of males at peak. This is in 1 year. If you look at the lifetime cumulative incidence, so you got 43% of females having episodic migraine. If you had chronic migraine and some other group described as probable migraine, I'll get to what I mean, then it nudges very close to 50% of females will have had some migrainousness during their life. That's a pretty heavy burden when you think about the biology on the community. And of course, it's this ratio which drives many perceptions about migraine. It's perceived to be a disorder of females. Well, fundamentally, that is more frequent, and that is true. It's a disorder of the reproductive years. You look at puberty starts, and then that dip in the female number occurs around menopause. women are still more likely to have migraine in later ages. But there can be very often very big changes around menopause. Very often you'll see women who are have menstrual-related attacks, or have milder migraine, and when they go through their menopause, things just go pear-shaped, and it gets much worse and gets more frequent. The only upside to that is, for most, and every rule that I'm going to tell you, almost every rule has its exceptions, but in the generality of things, when the menopause is finished, for that sort of person, they get substantially better. Migraine doesn't kill people. It's not associated with dementia. If you look at 80-year-old migraineurs, then they're no more likely to be gaga than any other 80-year-olds, so to speak. So it would be nicely studied by the French. So it doesn't shorten life, it just ruins part of life. So when I'm talking about migraine, and when the classification committee is talking about migraine, they use this rather wordy definition. And the words don't matter so much in particular, but the principles are important. So migraine consists of attacks. We think largely that the attacks in children tend to be shorter. That's why the 2 hours is there. And it's what you might describe as a syndrome. It doesn't require everything. So you can have, for the classification, we like 2 of one-sided pain, throbbing or pulsing, moderate or severe intensity, or aggravation of by routine physical activity, but not all of them. So many migraineurs, up to a third, will have headache on both sides of the head. Many, again, up to a third, will have non-throbbing pain. It doesn't all have to be moderate or severe. It tends to be more disabling the more severe it is. 90%, however, will have this aggravation or avoidance of physical activity. That's a pretty robust finding. We like to see, well, like it's not quite the right description, but we see nausea or light and sound sensitivity, photophobia and phonophobia. And again, you don't have to have all of them. So someone that's got one-sided, pulsating, severe pain, aggravated with movement and nausea, nothing else is considered to have migraine. Now, that might sound a little bit generous, but it's not considered generous at all. Headache people think about this as being actually a rather restrictive system, for reasons I'd be happy to discuss. So the people who fulfill these criteria, they almost invariably will go on to have regular attacks, and we know a lot about how they will respond. This is a more expansive way to think about migraine, because when we think about migraine, we think about it in 2 ways. We use the word in 2 ways. We use it to refer to the attacks, as in you are having a migraine. And then we also use it to refer to the disorder, as in you have migraine. So people with migraine have migraines, so to speak, or they have the repetition of attacks. As I said before, the less than 15 is episodic and 15 or more is chronic. It's typically a family history, various triggers. I'm going to come to talk about those because they're interesting in many ways. And there are symptoms which we're getting more interested in. One group called the premonitory or prodromal symptoms, which happen very often before the attack, often many hours, and can continue during the attack. Things like some mild neck discomfort or pain, cognitive impairment, brain fog, can often describe that way, mood change. We see things like yawning. Actually, remarkably, if you do diary studies, 95% of people who yawn as part of their premonitory phase will actually go on and have an attack. It's very reliable, and we have quite a good idea of what's going on in the brain. People feel sleepy, they'll feel tired, as in fatigued, they pass more urine, they have food cravings. And those symptoms all are reasonably well understood in terms of what the biology is behind them. And there are symptoms of what I call the typical symptoms that I pulled out of the definition there. Not all of them are in the definition. So 70% of people will have sensitivity in the head. It'll feel abnormal, even painful when they touch their head when they get a bad attack. It's called allodynia. And about 40% have vertigo, the illusory sense of movement. Often occurring, more than 80%, not often discussed, is the post-trauma, where tiredness, weariness, concentration impairment, batteries are run down, last for hours or days after the attack. So to say that migraine is much more than head pain is almost become a cliche in my world, but it's clearly true. And that's before I even mention the migraine aura, which is only about 25 to 30% of people with flashing lights and visual disturbance that, again, I'll come back to. I want to say just a few things about these premonitory symptoms and the relationship to triggers we've been thinking about for quite a while. And it's a general principle that if you've got migraine, you might think about, might apply to some people who are listening. It's clear that there's some data in the table there, but it's clear that if you ask people about their premonitory symptoms, then a good proportion will have light sensitivity, photophobia, before the pain starts, as a warning symptom, you might say. And a good proportion of people will say that light will trigger their migraine, just as a good proportion of people will say food triggers their migraine. Strong correlation with food triggers migraine to having food cravings during the premonitory phase. Very strong correlation between having light as a reported trigger and being light sensitive just in the early phases. So you might consider for a moment the possibility that some triggers are not triggers, but they're part of the attack already starting, because the premonitory phase is when the attack is starting. So if a person is light sensitive and then gets their attack, and light sensitive and gets their attack, and that happens 500 times, they might very reasonably associate light with their attack and think, well, that's a trigger. But if you put another pair of glasses on, you might say, it's reasonable to consider the possibility that actually the attack had started. And the reason that the link is reliable is not because it's a trigger, but because actually it's part of the attack. Now, this can be measured. So in this slide, I'm showing you what's called functional brain imaging. Because if you take a normal brain scan, a CT scan or an MRI scan in the tunnel in migraine, the structure of the brain looks pretty much normal, looks normal. But you can look at function. That work started a long time ago, looking at simple function like I wiggle my finger and parts of the brain light up that do finger wiggling. Okay. What we did in this study, Farouk Maniar was the first author, as you can see. We took people who had light sensitivity in their premonitory phase and those who didn't. And we looked at their brain scans using brain imaging. What we use is a radioactive tracer that measures water, so you can tell when the brain is more active. And the subtraction is on the right of that slide, and the little yellow area lights up in people who are light sensitive during the premonitory phase, but not before the headache starts, in comparison to those who aren't. That's the difference that happens. Now, that part of the brain, that's the vision part of the brain. It's not rocket science to suggest that the vision part of the brain might be involved if you're light sensitive. It's an interesting problem, but it goes to show you that this sensitivity to light is to some extent measurable. So it's not an imaginary thing. I mean, it is what it is, so to speak. And this sort of information suggests that it's reasonable to speculate that some of the things that are happening before the attack, well, they're real, and that they're what's driving some of the perceptions around the premonitory phase, the early phase. There's more detailed imaging. Again, more recent, we're using this time arterial spin labeling. This is an MR technique that doesn't involve radioactivity, so it's reasonable to do it more than once. And what I'm showing you are some areas on the top, one called the anterior cingulate. It's on the most left picture, the little red bits. It's involved in mood, for example. It's not so surprising when you think about some of these areas, the amygdala or basal ganglia, in terms of this restlessness, that the pain with movement, the deep parts of the brain that are involved in some of these things, like the yawning and the food cravings, or in the passing of more urine. That you can start to map what's going on in the premonitory phase. This is all the premonitory phase. And the reason we do the premonitory phase, we're so interested in it, is because pain's not there to complicate things. It's not just, what we're seeing is not just a reaction to pain, because there's not pain, which is helpful in analytic terms. So what we start to tease out is the pattern of changes that are occurring in parts of the brain that are involved in the disorder. to understand its biology. Because to understand it, if you're going to develop new therapies, you need to understand where the targets are, to analyse them, what the targets might be from a structure point of view. And it's also very unsatisfactory in general terms of migraine. It's always very unsatisfactory to say, well, everything's normal when you look at the brain, because it's clearly not when people are having a bad attack. And the function thing makes that a lot easier to understand. Let me say something about aura. So a typical visual aura on the top right-hand side of the picture there, so the jagged, typically sparkly lines, and they're jagged, and they're usually linear, and they expand. They leave an area where you can't see behind it. After 30 to 60 minutes, it's gone altogether. Medical people call that fortification spectra, because they look like forts, the walls of forts. There's a 17th century, it's a picture of a 17th century fort in Homburg. Not all that exciting as it is. The reason I have it is because the professor in Homburg gave me the picture and a patient had drawn on it, because I was stupid enough to be invited to speak there pre-pandemic. And actually, I flew to Hamburg instead, because I didn't really realise there was Homburg and Hamburg were different. He was very forgiving and told me just to go home and come back another day to actually the right city, and gave me this as a little present to remind me that Homburg is different to Hamburg, which I'm sure most of you already knew anyway. So what happens, what's going on when this happens? On the left-hand side of the screen again are these functional imaging maps. Blue means reduced brain blood flow, and red in this purpose is normal. So what's happening, and you see that blue bit is increased. So what happens is there's a change, a reduction in brain blood flow that's moving across the brain, and that correlates with the area of loss of vision. It's called something, it's regarded as a phenomenon called cortical spreading depression, because there's a decrease in flow and brain activity. It was quite an important breakthrough that our Dutch colleagues made some years ago, who identified, on the left there's a picture of Naarden in the Netherlands, but it's got the forts as well, fortification structures as well. What they identified are genes in people with an inherited form of migraine called familial hemiplegic migraine, where there's weakness down one side of the body as well as the visual disturbance. And one of the important genes, the most common one, is called the CACNA 1A gene. It's for a particular protein that sits on the cells that allows calcium to move through move into the cell. And when you get those mutations, that produces familial hemiplegic migraine, or what the underlying pathogenesis is. Now, if you take that mutation and you knock it into a mouse, as our Dutch colleagues did on the bottom right there, you can actually then have an experimental model of what's actually going on in migraine aura. And that enables one to really dig into the biology in a way that's just not sensibly possible in people with aura, because of the nature of the invasive things that happen. Among other things, these animals have changes. It's easier to turn on this cortical spreading depression phenomenon, which has been quite reassuring in terms of our understanding of the disorder. And that's where people are thinking quite a lot about migraine with aura. Let me talk about the pain for a few minutes. So the pain of migraine is what's called referred. And it's very often people hold the front of their head over the eye, front of the head. Why? Why do that? Why hold that? It turns out that the pain innervation and the sensation, the feeling innervation in the head is in four quadrants, it's in quarters, 4 parts. And on one side in 2 parts. At the front, from a line of the ear forward over the eye, is one nerve. It's called the trigeminal nerve. It's called the eye branch, the ophthalmic branch. And the back of the head, from the ear backwards, the nerve actually goes backwards into the spinal cord. It's called the greater occipital nerve, and it ends up going into the cervical spinal cord. So the nerves run to the front and they run to the back. They don't run over the head, or they don't run around the head. There's no nerves that do that. And what happens when they get in there is they go to the same place. So the nerves from the front of the head go down all the way to the second cervical level to do to make their connection, what's called a synapse. And the cervical nerves go all the way up to the trigeminal nerve, the fifth cranial nerve, the nerve that's involved in the face. So there's a group of nerves that sit, the group of cells that sit within the brain, in the bottom part of the brain, it's called the caudal part of the brain, that we call the trigeminocervical complex. The reason that people will report sometimes odd distributions of pain in the head is this system doesn't seem to be set up for localization, as in my pain is here, but rather for warning, as in my pain is involving the head, because the brain is largely insensate. And what's pain producing is the covering of the brain, the so-called dura mater. We've known that from work the neurosurgeons have done. On the left there, it's work of Findell, Penfield and McNaughton, who were manipulating the dura, the covering of the brain in humans when they were doing surgery for epilepsy or tumours. So they would avoid areas that they didn't want to disturb, so to speak. And what's reported when you manipulate the dura, the covering of the brain, is pain. And look at the referral, of course, on the top part of the head is there to over the eye and the forehead. The problem for the brain is that signals mix together in this trigeminocervical complex, and before they get to perception up to the cortex, the overlap in these nerve cells, their innervation, means that for many, it's really impossible to tell where the pain is. And in fact, it doesn't matter because you can't stick your fingers in the skull anyway. It's not designed for that. The main thing about head pain, really when to think about it, is it's all around timing and severity and so forth. Localization is it's not actually useful at all in primary headache disorders for this reason, that the system that's involved is not designed to do that. Another important thing that we understand a lot about are some symptoms that are called cranial autonomic symptoms. So about 70% of people with migraine will have some eye watering or redness or nasal stiffiness or running, sense of ear fullness. They might get some drooping of the eyelid or swelling around the eye. Could be on both sides. Could be mild, but they'll notice it. Very often gets misdiagnosed as sinus headache, particularly if it's recurrent. And what it is that if you create pain in the head, you activate this cranial autonomic pathway which produces those symptoms, no matter how you do it. Whether it's with migraine in what's called the trigeminal autonomic cephalalgias, where this is very prominent, or if you do it yourself. So you might have had the experience that if you have a curry, you sniffle a little bit. It doesn't make any sense. Why would a curry do that? I'll tell you why. Because it activates these trigeminal afferents. It activates this pathway. We understand a lot about how that's done. It's called a TRPV1 receptor. I hate to ruin your curry for you, but the physiology of that is really, and the pharmacology is really well understood. You can give yourself pain if you want. There are various ways to do this. One of the more reliable ones that one of my German colleagues was interested in, started doing some research with. If you take a pair of tweezers, little eyebrow tweezers or little tweezers, and you pull nasal hairs out of your nose one at a time, it's very painful. And you'll notice, if you do a couple, that you'll get some eye watering and maybe, if you like, a bit of nasal stuffiness. I've had concentrated ammonia sprayed into my nose as part of one of my German colleagues doing a research project. That's very unpleasant. And I remember my eye watering with it. I thought it was exciting for the first couple of seconds until I thought about the pain. The pathway is very well understood. Treatments. What's happening with treatments? Well, the treatments really have moved on in the last 20 years, or 30 years. When we first started practicing, there weren't even these drugs called triptans, like sumatriptan. Things have really changed. We think about the treatments in two ways. We think about them in terms of things that are just for the pain, like aspirin or paracetamol or ibuprofen, and things that are directed at migraine. Ergots are used, but they're not used as much. Oh, I saw a chat. I'm going to come back to the questions in the chat, I think, because I'll just get to might be a better idea. I'll get confused if I keep looking at that chat thing. But thank you. I will get back to the chat. Triptans, there are a range of these. These are all available in the UK. They're available in various formulations. UK doesn't have the rectal formulation. It's popular in Scandinavia, but you know, there are many options for these things. Sumatriptan has the most variation in terms of formulation. There are new medicines called ditans, lasmiditan, not available in Europe yet, that are used in the US, that have the particular advantage that they act through a serotonin mechanism, but they don't do anything for the blood vessels. And the latest thing that's coming along that NICE is thinking about at the moment are called and are available in the US. There are two in the US, Remagipan and Ubrogepant. And actually there was just a third approved about a week ago called Zavegepant. NICE is looking at one called Remagipan, and I'm going to return to that. As I talk about these things, I wouldn't want you to think that everything works. So it's a busy sort of slide, but I just want to point out that there are in the middle, that there are various things that are being tested. Blue is placebo sugar tablets, you might say. Yellow is the active substance. And there are various things on the left of the dotted line that have been tested and were just useless. And I don't say that to be proud of it, but to say that things that work in migraine, look at the right side, how big the yellow bar is compared to the blue bar, and look at the left side, how not different the two are, because they're these what are called substance P antagonists, the plasma protein extravasation blockers that were tested, all failed miserably in randomized controlled trials. And that's, I don't say that with pride, but to say that the things that work, and you start to understand by things that fail, what roads you don't want to continue driving down, where you don't want to waste resources, which is the point of saying that. Now, the most recent things that have happened around CGRP, or calcitonin gene-related peptide, and that's some work that I developed with Lars Edvinsson. We met in that splendid building. That's what the Swedish call a castle. I'm sure the English would just call it a stately home, but anyway, it's called a castle in Sweden. We constructed experiments in the actually in the mid-1980s, and eventually started publishing them in the late 1980s, to show that this substance, calcitonin gene-related peptide, was increased if you stimulated the trigeminal system more broadly, and specifically just increased substance P0 in migraine, and that you could reverse that effect with a triptan. And we evolved what was called the CGRP hypothesis at the time. And the test of that has been these tablets, these small molecule CGRP blockers called GPANTs. Remagipan's the one I'll come back to. The first test was given by the vein intravenously, one called Alsegipant there. It was never commercialized, and so that was stopped. Two of them went to clinical trial and died. There's a little sick liver emoji there, had hepatic liver problems. Again, blue is placebo, yellow is the GPANT, and the mauve on the right side of the dashed line are triptan, zolmitriptan, elytriptan, and sumatriptan. The MK307, the same, had hepatic problems. The Boehringer people didn't think they'd make enough money out of 44370, so they stopped that. And the other three have gone ahead. And as I say, they're all three now are available in the US, and NICE is looking at Remagipan. So the CGRP hypothesis was that if you block the effect of CGRP, you'd have an anti-migraine effect. And this worked, and it's worked on all 7 medicines that were tried. I'm not going to bore you, or may not be the right word, but I'm not going to tediously go through every one of the clinical trials that's ever happened. But I will point out, because it's probably more useful at some level, to say, what if, how does this relate to triptans? We've got quite a lot of understanding, because many people have had a triptan already. So what is that? What can you learn from that? And these are what are called post-hoc analyses. So you take all of the phase 3 studies, you allow people in who've had triptans or triptan contraindications, you go back and you put them together and ask yourself the question, if you've never had a triptan before, and again, blue here is placebo and yellow is the GPANT, Remagipan on the left and Ubrogepant on the right. And if you've never had a triptan, you can see either Remagipan or Ubrogepant, you'll still respond to the drug. If you're a current user of a triptan, you went in the clinical trials, see what happened, you'll still respond to the drug. Happily, if you're a person who's failed efficacy or poor tolerability to a triptan, then you'll still respond better than placebo to the Gpan, to the rimagepant or the ubrogepant. Or if you failed 2 or more triptans, lack of efficacy, poor tolerability, you're still just as likely to respond as a person who's currently using a triptan or never used a triptan. So from the point of view of the person who's not got responses out of triptans, this is pretty good news. I think that having therapies that we can give to people who don't respond to current medicines seems like an obvious development, and I do hope that NICE see it that way. We shall see. On prevention, bit of a shopping list. There are sort of 3 big buckets. There's what people do, I'd say lifestyle, behavioural things, the nutraceuticals for which there's some evidence. There's the old drugs. If you've been on preventives, many will have been on propranolol, the trade name may have been Inderal. Many might have been on Pizotifen, Migraine. They're both drugs which are in the British National Formulary that a GP would look up and find that they could use. Many would have been on tricyclic. Some would have been on topiramate. Some on flunarizine, although it's licensed in Europe, was easy to use, still pretty easy to use in the UK. Was never licensed here because they never thought they'd made any money out of it. Some might have been on candesartan, a drug I think is quite a good of one of the old drugs. If you've got chronic migraine, you might have had botulinum toxin. The new drugs that we have, all of these now in the UK, eptinizumab, arenumab, fremonizumab, and galcanizumab, are what's called monoclonal antibodies. So what they are antibodies that either mop up, they bind to the CGRP and don't allow it to have its action, or they bind to the place where the CGRP works, the so-called receptor, and don't allow it to have its action. Rimagepant can do the same thing by blocking its prevention, and there are various neuromodulation approaches that I won't go into too much detail. This is a transitional, this is why monoclonals were developed. On the bottom right there is telcagepant, the drug I said that it failed in hepatic toxicity, and this is how it failed. It worked in the acute treatment, and the company, with advice, myself amongst them, suggested maybe it'd work in prevention as well. So they put it in a preventive study, and it worked. And the placebo rate, 22% again in blue, is the same as for the topiramate studies or the candesartan study. So it's broadly in the same place. However, 2.5% of people had liver enzyme problems, and that's what killed the drug. And because these what are called first generation Gpants had died in this hepatic toxicity, the monoclonal antibody people had a target, and they had a way of doing things because you don't get hepatic toxicity from monoclonals. And so these monoclonals were developed. They're now available for migraine. Galcanizumab has evidence in cluster headache, although the European Medicines Agency didn't quite see that. We know a lot about them. On the right is what's called X-ray crystallography. So you can look at actually how the molecule of the monoclonal sits, and the blue is the CGRP, and how the CGRP sits and is bound to it. It doesn't make a blind bit of difference to clinical practice, but it seems to me, I'm very attracted to understanding what's going on. We know, for example, the top right hand, that little one marked 7, the flat line is the fremonizumab molecule. If you take just 3 amino acids out of the area of the molecule that normally interacts with the immune system, it doesn't do anything. That's why we don't have opportunistic infections or other immune problems with these antibodies, because they've all been specifically engineered to avoid that. And we know why and how that works. And I won't show you all the data with the monoclonals, but I'll just point out to, on the right there, is the failed previous preventive data. This is what really convinces NICE, because they're interested in obviously trying to provide therapies, I think, for people for whom other things don't work. So all the people who got in these studies, it failed between 2 and 4 preventive classes. And what stands out as a clinical trialist is the placebo rates are really quite low. These are 50% responses, and about 3 times as many people are going to respond to the medicine as to the placebo. Of a lot of mepolizumab does pretty well. That's an intravenous formulation which just become available. The rimagepant people noticed the same thing on prevention. This is a study that took people who were using it episodically, and either let them use it 2 to 8 times a month, in which time nothing got worse and nothing got better. It just didn't, the attacks worked, didn't change. Or at the other end, they used it every other day, the teal colour, and you see the drop in attacks. Because a really remarkable thing about this class of medicines is they don't produce something called medication overuse headache. You see, the more you use, the better you get. If you did that with a triptan, the more you use, about 30% of people will get worse. Their frequency will go up. It's quite a disruptive concept. And it'll be a little while until people get their heads around it, I think. Let me go to this one. This is some real world evidence just to say what happens with these monoclonals. These are our Swiss colleagues. And some of our colleagues in Europe have had very strict government rules. So they had a baseline of treatment here, you see, and after 12 months treatment, there was a substantial reduction at the first panel. Now, the government mandated that they then had to stop treatment. Everyone who responded had to stop treatment because that was just a rule. And like a Swiss clock, they did it. And you see what happens. If they stopped treatment, it went up again. And then when they went back on it again, it went down. So, the good news is that if you stop treatment, you go back on it, it's likely to work again. The bad news is if you stop treatment, well, things get worse. Not for everybody, but for a significant proportion. This is the same sort of data. Again, very disciplined data from our Italian colleagues showing the response rate, so not reductions, but the response rate. So they're up in the 70% odd for the high frequency episodic migraine people, 60% for chronics. And then if you stop the treatment, you see the response rates drop, so many less people. What's happening, I think you could see, is about 2/3 of people who are responders, if they stop their medicine, will have the thing come back, and about 1/3 don't. So they're difficult to decide what to do in some ways. And then the other thing which is quite interesting is on the right is if you persist taking the medicine. So if you take it for more than 12 weeks, a proportion of people, 14%, convert from being non-responders to responders. So for some people, it takes more than the 12 weeks to get their effect. This could be the distribution of migraine, but it's actually the distribution of these monoclonals or of the GPANs. 80 odd countries in the world now. People are really catching on to this. It didn't come down with the last shower as one could see. Not enough places, but certainly the UK there and all over Europe. This is a broadly used medicines. We understand a lot more about migraine now than we did. We understand a lot about which parts of the brain are involved. We're starting to understand about these premonitory symptoms. We understand a lot about the distribution of pain, and we understand a lot about how the medicines work and what the new medicines are likely to do. And that provides, to me, a lot of enthusiasm that things will get better, have gotten better, and will continue to get better. And with that, I'll stop.
Very grateful to Peter for giving us your evening and your expertise,
Sure.
your vast experience. So, and it's nice to see you again as well.
Yeah, good to see you. Good to see everyone.
Thank you, everybody, and good
Cheers.
night.
Good night.
Thank you.